Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about diabetes mellitus type 2 and its many associated problems that are really ravaging the human body and those that are affected. Across the world, uh, 425 million people suffer from hypertension, suffer from diabetes mellitus. 22 million of them have type 1 diabetes, and about 10% of pregnant women across the world has gestational diabetes. Very common problem. Every 6 seconds, somebody is killed by diabetes-associated problem across the world. And altogether, 1.6 million people die every year from diabetes mellitus across the world. In this country, 79,335 people died of, 79,535 people died of diabetes mellitus every year. It's a common problem. And altogether, 30.3 million people have the so-called type 2 diabetes, and close to 100 million people have what they are calling pre-diabetes, which in my view really doesn't exist at all. Now, when I left off last week, I was ordering blood tests of different types in preparation to discover whether or not somebody has hyperglycemia or not. And then in this segment, I'm going to evaluate the situation again and begin to tell you what really is going on when somebody's blood sugar is elevated, a condition called hyperglycemia. Somebody's blood sugar comes back elevated, let's say, from 125 or so around 130, then they're calling that frank diabetes because it is frank hyperglycemia, and you want to start treating the patient. You want to take a look at the A1C. Now, there's a confusion about A1C. You see all this stuff on television about A1C. A1C, when it is elevated, it basically tells you that the blood sugar was elevated within the last 90 days. That's really what it's telling you. The A1C should not be used to diagnose diabetes. If you suspect somebody has symptoms such as numbness, tingling, and dry eye, blurry visions, urinary frequency, a whole host of other nervous associated problems where the nerves are damaged, you want to know whether it is diabetes mellitus that's causing it. You evaluate the vascular problem. You do a test to evaluate the vessels around the leg to make sure that there is no occlusion in the arteries, etc. Then you would proceed to fasting blood sugar, as I just mentioned. You could do the A1C at the same time if you want to, but it's not necessarily because you're doing the A1C to diagnose the diabetes. You're doing the A1C if it is elevated. That tells you that the blood sugar that's elevated have been elevated for about at least 3 months. That's what it's telling. If you really want to diagnose diabetes mellitus and somebody really has symptoms that you think may be due to diabetes, you do glucose tolerance test. There's the 3-hour glucose tolerance test, and there's, of course, the 5-hour glucose tolerance test. Pretty simple stuff, but I'm not going to bore you by describing how it's done because that would take too long. Suffice it to say, that's what your physician, whoever is practicing medicine for you, should consider doing. It's a glucose tolerance test. If you're having all these symptoms and then you're not hyperglycemic, then a glucose tolerance test will tell you if in fact you have type 2 diabetes, but you're not yet hyperglycemic. Big difference. Diabetes mellitus is not the same as when your blood sugar is elevated. You may be diabetic for years, and yet your glucose is not elevated yet for a variety of reasons. I've gone through this over the last several weeks that I'm talking about diabetes mellitus. I'm not going to repeat them again. Now, also, another thing having to do with A1C that you got to be very careful. There are hundreds of millions of people across the world if not more than, for instance, let me give you an example. 1.5, 1.3 to 1.5 women across the world have iron deficiency anemia. So, I mean, anemia is a very common problem. Billions of people suffer from anemia of different types. The point you have to understand when you're talking about A1C, A1C all the time you see on television, A1C is a hemoglobin. It is in the same family as the regular hemoglobin we use to know whether or not you're anemic or not. So if you're anemic, your A1C is going to be is accordingly low. The A1C is going to be accordingly lower in individuals who are diabetic, who are anemic. And I'm telling you, okay, there are more people in the world that are anemic than there are people that are diabetic. You have 425 million people who are diabetic, but you have several billion people who are anemic. Sickle cell anemia, the thalassemias, iron deficiency. You cannot be a menstruating female and don't be iron deficient. You cannot be a woman who gave birth and don't become anemic because of it, because every childbirth that carries to term, the mother loses 750 milligrams of iron. Let me repeat that. Every child that a woman carries to term, she has to lose, this is by necessity, 750 milligrams of iron during that process, because the fetus is sucking up all that iron. And and if the woman is breastfeeding, tremendous amount of iron is lost in the breast milk as well. So the number one disease of women across the world is anemia, and of course it's iron deficiency anemia, okay? So, and you have all these ladies also can be diabetic. And then people making all this big deal about A1C, they don't understand the A1C, the same family, it's a hemoglobin. It's in the same family as the hemoglobin that we use to check for anemia. So therefore, the lower the total hemoglobin, the lower the A1C is going to be. So the A1C has to be evaluated in context. Okay. Now that I've gotten that out of the way, we're going to get into the business of trying to treat somebody or not treat somebody who is diabetic. One of the major components of treatment of diabetes, of course, is the diet. A diet that is free of simple carbohydrate. Because all simple carbohydrate, and the list is extremely long. I have a page and a half in the book, either one of those books that's in front of me, of all the simple carbohydrate. All simple carbohydrate by necessity must turn into sugar and into fat. So the more simple carbohydrate you eat, the more obese the person is going to get. So diet is a major problem, in particular in America. Of all the developed countries in the world, there are more obese individuals in this country than any other developed country, because you are loaded with fast food. There's a tremendous amount of poverty in America. This rich country, you have millions and millions of people, adults and children, going to bed every night with nothing to eat. When they do get something to eat, they eat what they can. Okay? I've been there. I know exactly what this is all about. I don't want to be personal about it, but it brings memory. When I came to this country, I was working in a factory, H. Goodman and Son, I don't mind naming the factory, H. Goodman and Son, making the hair rollers, the old-fashioned hair rollers for women to roll their hair. Well, I was making $1 an hour. All I had access to was American cheese, Wonder Bread, and some Kool-Aid. That was my lunch. There was no breakfast. There was no money to eat breakfast with. And for dinner, I would go to the store and buy, I couldn't afford regular chicken. So I would buy the back. You know, they cut the meat out and they have packs all the bones and the backs together in a package. I would buy those, a pack of those, and I would buy fine little noodles, the fine little noodles, the little spaghettis, okay? And I would boil those things together, put a little salt on them, and then put it in a thermos, okay? Can't make this up. So when my shift was up, take away the dirty clothes before I head toward school. I was going to college and high school at the same time. I would just wash up a little bit, open the thermos, eat some of that stuff, well, as fast as I can. I got to get to school as fast as I can, and then leave the rest in the thermos and go to school. And I had these big valleys. I was always all dressed up with my necktie, and if you see me, you'd think I'm working on Wall Street. And in fact, I was working in the factory. But I always remember to dress properly. And when I get home at night, and home was always midnight because I had to stop at the 42nd Street Library to do my homework, because if I go to that $7.50 room that I was renting with all the people around me making noise or scream, whatever, I couldn't study. So I would wait until I get home at night, late, after midnight. I was probably one of the last person before they closed. That was my home, the library. They would close, jump with my 15 cents token and go uptown and get my little room, and then the noise, people will never go to sleep. So and I would have to get up at 4 o'clock, because if I don't get up at 4 o'clock to head to the shower, I couldn't get into the shower because everybody else is using the same bathroom. So, and I know exactly what that is. And believe it or not, as bad as that was, to explain to you what I know about poverty, there was a period of my life that was worse. When I was in Haiti, as an orphan, my parents died, nobody would give me anything. And sometimes I spent days without any food because, for whatever reason, my siblings were taken over by different family members. Me, a little boy, because I was so intelligent, people thought that I was arrogant. Can you imagine that? So they hold that against me. So nobody would give me a little bit of food. So, I survived. As bad as I suffered from hunger here, I suffered from hunger more when I was in Haiti. Now, all the Haitian folks, many of them heard that this Dr. Alcena had become, quote, famous. Everybody knew me. These people had nothing to do with me. I was the last person they would have done anything for. And this country, as tough as the beginning was, opened the door for me to be here talking to you on television as one of the leading physicians in this country and one of the leading physicians in the world. Nobody, no other country would have given me that opportunity except the United States of America. Yes, there are problems. But in this country, if you have brain power, people, your teachers will discover you. They will open the door for you, because all teachers, and I'm a teacher myself, love intelligent students. They will help those that are not so intelligent as well, but they love intelligent students. They will open doors for you. Nobody closed a door in my face in this country except one guy at Hunter College who would not meet with me because he said I was not medical school material. He wouldn't let me join the pre-med program at Hunter. But the very same day, somebody else gave me that break. I got into my car. I hate to tell the story. It was a true story. I got into my car, drove to Queens College. God said go there. I went to Queens College, asked the guy who was in charge of the pre-med program. He said, well, it's over there in the genetic building. I went there and got into this major argument with this black lady that was, well, in those days it was not black, it was Negro lady. That was the secretary. She gave me a hard time because I didn't have an appointment. I'm trying to explain to her, I took one day off. I can't afford to take 2 days off. If I do, then I can't pay the rent. And this gentleman who was in charge overheard me arguing with this lady. He came out and said, "Sir, I'm Dr. Daniel Mariam. Mariam, Marion, Daniel Mariam. Come and talk to me. Come inside." So I came in. He said to me, I told him what the story said. "Show me your grade." And sure enough, I had paid $10 and get my grade from Hunter College. He said, "You got to be kidding me. With this grade?" I was a straight A student, even though I was working so hard, straight A student on the dean list. This guy will not allow you to. He said, "You know what, sir? You could come and join me, join my program in September." That's how I wound up, stopped going to Hunter and went into Queens College because of Dr. Mariam, Daniel Mariam, who opened the door for me. Okay? Because you look at my grade, not because I had an aunt or a niece or an uncle that referred me. I referred myself. Look, the grade opened the door for me. And of course, Dr. Mariam was the one, believe it or not, who packaged me and sent me to Einstein. When I'll tell you that story another time. He came to my medical school graduation. Okay? That's how I wind up becoming a physician. I was rejected at Hunter College, but accepted at Queens College the same day. Okay? So this is why I said to you, poverty is a disgusting thing, but it's not a shameful thing. It's a hard thing. There's nothing shameful about being poor. You just have got to hang in there. When you're poor, you can't eat proper meal. So who am I to pass judgment on these people that have been there? So this is why there's such a high incidence of obesity and such a high incidence of diabetes mellitus, because the more junk food that you eat, the junk food are packed with salt, packed with simple carbohydrate, and packed with spices and grease. But that's what you can afford. And to wash it down, you drink liquid that's loaded, also sodas that are loaded. In my case, it was Kool-Aid that kept me alive, okay? So I don't even send it. They still sell Kool-Aid. Maybe they still do. I don't know. So I'm not ashamed of my background. In fact, I'm proud of my background. I suffer from it every day, because when I am working at a hospital right up the street on Davis Avenue in White Plain, some of my colleagues resent the fact that, number one, they had to take the M.A.C.P. I didn't have to. Number two, they had to finish their training to have a license. I didn't have to. I got my license a few months after medical school. I didn't have to take the M.A.C.P. because I had done incredibly so well. The stuff that you see on television every day talking about Humira and all this other stuff, that's the research that I had done, not for this specific biology, but the research that I had done using my brain at Brookdale Hospital that allowed me to get a letter from my boss to take to Einstein, a letter to send to Harvard. Because when I done it, I said, "Oh my God, you got to be a genius to do this." And this is the research that I had done using methotrexate that is still being used today. I still use methotrexate in my office to treat all this stuff you see on television. That's where that came from. That's how I get into medical school, okay? So this is America. You got to discipline yourself. Just because you are being discriminated against every day because of the color of your skin, that should motivate you. The anger should be translated into positive anger. There's positive anger, there's negative. I'm not here to tell you what to do, but I'm telling you positive anger is constructive, negative anger is destructive. The people who are doing these things to you, they specifically want you to destroy yourself. They want you to make you so angry that you wind up destroying yourself, getting in trouble with the law, doing all this crazy stuff that you're doing, which is demeaning the entire Negro race because of your bad behavior, because you're angry. No one should say you shouldn't have any right to be angry, but you use the anger in a positive way. Get yourself a job. Even if the job pays $1 an hour, get that job. And work hard at that job. Be good at it. So the people that you're working for can help you to go ahead. and then go to school. The formula is school. Believe me, no other formula works. It is the schooling. Not only that you educate yourself, that you remove the shackles from your legs, you're now able to think for yourself, make proper decisions. Every single day, I'm making major career-saving decisions on my own, while I have folks who are so angry, so jealous, and so envious of the fact that I am who I am. I've achieved what I have achieved. And even if they live for 10 billion years, they cannot achieve half of what I achieved because they don't have the DNA. They don't have the, I'm a professor, I know who's who. They just simply don't have the IQ to get where I am. They have the privilege. That's their right. Let them be privileged. But the one thing they're not privileged in is brain power. They just don't have the IQ. If they did, I'll be the first one to know, because I teach some of the smartest human beings in creation all the time. And I know what brilliance is. I know what mediocrity is. So in any event, obesity is a big problem. So therefore, when you're evaluating the blood sugar, you're about to treat someone. If the person is obese, that's very important. If the person is very thin, that's very important. Your kidney profile is super important. Why so? Because 15%, before you start the treatment, 15% of the glucose that is metabolized in the human body is metabolized with the kidney. So therefore, when you examine the kidney profile, that's crucial. Because if the patient kidney test is abnormal or insufficient, you have to adjust the medication accordingly. If the patient is obese, you have to adjust the medication accordingly. You don't want to start giving a patient who is obese a lot of insulin unless you absolutely have to. Because if you cannot produce insulin coming from the pancreas, you have no choice, but you have to use insulin. Keeping in mind, the insulin, important though it is an anabolic steroid. The more insulin you give to the person, the more anabolic you make in the person, the more hungry the person is going to become, the more they're going to eat. And the reason why they eat so much sugar-containing food when you give them insulin, because that's what they need to replace. The body knows they need the sugar because they're using sugar because of the insulin. You could make the patient more obese with the insulin, because the more insulin you give, the more anabolic. Anabolic means you're building up. Catabolic means you're destroying tissues. But if you have to, you have no choice. So you're taking all this into consideration, then you're going to start treatment. The first treatment, of course, you're going to start is not necessarily insulin. It's probably going to be an oral agent. There are several oral agents in the market. I brought a list here with me. Some of them I'm more familiar with than with others, because I don't use the new ones. I'm so accustomed to the old ones. Okay, metformin, I use that frequently. I use diabeta, glipizide, I use this very frequently. I use Genuva very frequently. Those are enough for me. I don't have any patient in my office that's taken anything other than metformin, diabeta, glipizide, Genuva. I'm able to manage all my patients like that. I don't have a single patient in my office whose blood sugar is not well controlled using those medications by mouth. The new ones are fine. I know about them because I know about the giants of the world. I know about all this other stuff. I have to know about them because Fasiga. I know all this. They're good medication. But because I'm a writer, I have to write them down. I have to teach them to the students. But that doesn't mean I need to use them. I haven't had to, because I don't have any issue with the old-fashioned ones that I've known ever since I started practicing. They're still around, and they work fine for me. In particular, if someone is obese, you need to do all you can to put them on metformin because metformin does not work at the level of the pancreas. Metformin works at the level of the circulation. Because of it is the metformin allows the insulin to be pushed to push it through the fat cells. So all obese individuals should be placed on metformin unless there's a contraindication to it. If the kidney has completely failed, then you got to be careful because you could develop diabetes, you could develop acidosis from that. Be careful. So then you of course have to decide what's the second medication going to be, because it's not going to work at the level of the pancreas. You could add diabeta to it. Diabeta will stimulate insulin production, causes the pancreas to pump the insulin down the stream, and the metformin will pick it up and push it through the fat cell to control that way. Now, if the patient reaches a point whereby he or she can no longer benefit from insulin, from the oral agent, then naturally you have no choice. You have to keep the patient alive. Then you're going to have to start using insulin. That's when the patient becomes insulin dependent. And on sometime while the patient is insulin dependent, you could still use metformin if the patient is obese, because I told you how metformin works. So metformin is used reasonably frequently in individuals who are also insulin dependent, because as you give them the insulin, the metformin facilitates the entry of the insulin that you're giving them into the cells, so as to bring the blood sugar down. Now, you have to understand the beauty and the value of insulin cannot be overstated. We can't survive without insulin. And next week, I'll begin to tell you how we actually use insulin to treat diabetes in an acute setting, in a setting where the patient is completely, totally insulin dependent, and how the insulin works, the different types of insulin, and so on and so forth. So I'm taking my time. I know you've been waiting for this medication talk a long time, and I'm sorry I took time to talk so much about my past to you. Until I see you again, this is Dr. Alcena saying so long and bye-bye.